Good afternoon, everyone. Thanks, Raf. My topic is the role of artificial intelligence in robotic surgery. Are we headed for driverless cars? I'll just rush through some of the major things. I won't go into the depth of what is artificial, and we don't have to learn Python or C++ or other computer languages to understand. We are the end users. See how the Ray Kurzweil from Google, he said 21st century is of 100 years, but the technological progress is of 20,000 years. And we the humans can communicate at a fast, it is very less, 10 bits per second, but the machines can communicate, the robot can communicate at 100 million times faster. And why the technology we have to use is, when we see the complications that is happening, it's third, preventable human errors, surgical errors are the third leading cause of death. And 25% is technical and 75% is human factors, because the decision making, its communication and the team leadership. And they have seen that the surgical complications are more with the lowest quartile surgeons. And we the humans are, why the artificial intelligence has come into the field is because of the human biases, they're like framing to the confirmation. We have lots of things as a human being, the weaknesses in understanding things or taking a decision. And I'll just rush through the artificial intelligence. It has, this healthcare industry stands at present in 2022 at its inflection point. You can see lots of things happening in the field of medicine. And AI, even though it's introduced 6 decades ago, it's a computational tool that reproduces or simulates the human intellectual process in problem solving, reasoning, and as well as learning. And at present, we have multi-parametric and big data, and these big data and the multi-parametric informations that allows us to cross talk between the computer systems and human. And when you see the artificial, it's not the machine learning and deep learning, it's not one and the same. It is like when a person goes for an MBBS, it is a broad specialty, it's like an artificial intelligence. When you go as far as in the deep learning, it is an MS, MCH and the fellowship. This is how it is being done. Then this artificial intelligence took long time to permeate through the world of surgery. But at present it's advancing at a pace and we cannot ignore it, and helps in complex assessment beyond the capabilities of the most of the surgery. And at present what we have is more of computational data is there. We have parallel computing, we have quantum computers and all this big data and better algorithms, whether we can neural networks like our brain, the cognitive function of the brain is being translated into the artificial intelligence, and broad investment that recently when you see the Wall Street as well as this approximately 9 or 10 companies in AI is invested in healthcare industry. And coming to the machines, machines use algorithms to learn from the data, improves from experience without being explicitly programmed. And there are different types of learning, like supervised is, unsupervised is the reinforcement, like is in a childhood. Reinforcement, that when the computer says that it has selected as a good, you give a positive reinforcement, and if that's how you train the computers. And deep learning, the machine learning algorithms that use multiple layers to progressively extract higher level features from the raw point and based on ANN. And without, when we come to the as surgeons, without touching upon the pathology, we cannot go into the surgical field. Now IBX Galen prostate, it has given a 37% productivity gain and 27% reduction in diagnosis time, and significantly lower rate of discrepancy with the AI and humans. And what this digital pathology, you can see that it will identify the pattern, and this pattern is, suppose the Gleason score, how is the architectural pattern, it will take the pattern, it will understand, and then they'll give the algorithms. And improved diagnostic workflow is improved support services, better task prioritization, and assist pathologists. And this is how earlier when we were the students or something, like most of the time from the pathology we used to get the histology, this hematoxylin and eosin stained preparations, they'll say, oh, the specimen is then for immunohistochemistry study. Now with the immunohistochemistry study itself, the color deconvolution is possible, and the epithelium channel and manual annotations to remove that, and the training to the computer. And along with that, hematoxylin and eosin stains, and along with that you can get the IHC report along with that. And how good is the artificial intelligence? In Gleason grade, from 0 to 1, if you give, and it has got compared to an average pathologist, slightly better the AI system, but it's slightly less than the unexperienced pathologist. And now coming to the small additives in the AI in the surgical field, virtual 3D models, 3D organ reconstruction from the standard images, and this virtual cystoscopy is there. This again the AI's computer is trained to identify from the multiparametric data. You can see the tumors. Suppose there are 3 tumors, 4 tumors, 5 tumors, how they identify, and this can be fed into this data can be fed into the computer and can be trained. Then another one is the augmented reality. That is the superimposition of the 3D virtual models over the real anatomy, allows the surgeons to see beyond the hidden anatomy and tailors intervention for individual patients. And this you can see again. This is what we were discussing in the morning. And partial nephrectomies, we have the data, but the problem with this is the patient, these investigations are taken in the radiology department, and the 3D reconstruction also is happening, but the patient is anesthetized, and this is the movement of the patient along with the respiration. And also, like when you use a small instrument for retraction also, that also goes for a deformation, and when you overlay the images, there will be some discrepancy between the imaging as well as the real-time scenario. But elastic reconstruction is coming up, and this has got a real-time movement, accurate overlapping, and intraoperative navigation. And now coming to the artificial, whether we are better than the humans. You can see this is the Google car going there, and it is hitting the pedestrian, and finally this patient dies. Now, where we lie with the question is whether the robo is going to take the control from the human surgeons. We always have the advantage. We have the cognitive thinking, we have the experience, we have the predictability and surgical decision making. Another one is intelligent clinical decision support system, valued member of a multidisciplinary team that will integrate the pre-operative biochemical, radiological and sequencing data, and at the press of a touch of a button, like a Gleason, like a Parton's nomogram or Briganti nomogram, we can make out what this patient, this is going to be a personalized medicine, and they'll know that suppose a patient comes to you seeing his appearance, his biochemical parameters, his radiological features, so this person is going to get this kind of investigations. It is a probability of complications, morbidity, mortality, as well as everything. And even the AI colleague will tell us that whether the determine the given surgical team's suitability to perform the operation, and generate surgeon specific complication profile for each procedure, and accurate visual sensors, real-time tracking as in driverless cars. Now coming before the autonomous robots, we have the supervised robots, and in this supervised robots, his robo's work is being supervised, and the first step in integration of autonomous robo is supervisory control of the surgical task. And till now, the artificial, this AR surgery was on the predictable anatomy, like the bone or the spine, because everything is predicted, that there is not much of a movement. And there was a limited use in soft tissue tasks that requires repetition, precision, and accuracy. And this is going to be even the miniaturization and the instruments and the software and the hardware. It's going to be in the vascular surgical field also. And recently, off late, we have seen in 2021 late that Star Robo. It is an autonomous supervised robo and doing a bowel anastomosis. And in this also, we can see that we have to be, the nurse has to be somewhere removing that stitch. You see, we have to remove it. And this focusing is done by NIRF. There's a near infrared focusing is, and very precise. They have seen that best of the best surgeons this anastomosis, this is better. But there are so many things, like in the soft tissue, it will be moving inside, because it's in a laboratory where the ends are fixed, it's okay. Once with the respiration and the anesthesia, how far it will be able to replicate a surgeon's movement, it is questionable. Now coming to the autonomous robots, autonomous robo ISO definition is ability to perform intended tasks based on current state and sensing without human intervention. This is the ISO definition, and this actually is going to expand the human capacity, capability and dexterity, and this next ones is the soft autonomous robots. Then these are all the safe, robust robots, interact and adapt to humans in a natural environment better than the rigid robot. This is just slowing. This is in the oceanic industry, it's there, and slowly is percolating into our. And this has got lots of future also, future as well. And the thing is made by the hydrogels, electroactive polymers, and granular media, and it's not hard. It is like made of a silicon type. And this has come into the experimental lab is Octobotis, and what it doesn't require an energy source. It requires that the gas which is produced by the combustion of the chemical reaction, that will be the fuel, and it will percolate through the pneumatic channels, and it will activate the movement. And fully autonomous robots is a grand challenge, requires soft analogs of the control and power system. You can see that this is the robo, the inspired by the octopus. See the movement of this is multiple, and this the 3D printing is done in pneumatic chambers by the 3D printer inside of it. And in that there are small channels are there inside, and this hydrogen peroxide washes over tiny plates of the platinum. Then the gas will be produced, and the gas will go through that small channels, and this will go and it will go through the one arm, and it might flex it at that time. Then it goes ejection, then start moving in. So once you put in the abdomen itself, it can start moving and start, at least it can hold the camera. But the problem what is going to happen is you should have, this is just the robo, you should have a software, hardware, and all the ancillary things are there. So one more, the last slide in this, the surgical robo of the future, how it will be like, it is not going to be a master-slave relationship. And initially it was the surgeon, the robo, and as a slave, and the patient. Now when the surgeon's console, when the robo starts sitting, the patient equation is going to change. The custodianship of the human surgeon and the robo and on the patient, and the relationship and the ethical issues related to that. And the surgery 3 is going to be different from surgery 1. Surgery 1 is the web 1 was passive readership. Now it's interactive, integrated artificial intelligence, again it's coming. And finally the last thing is the ethical challenges. There are lots of things. Around 1985 was the first robotically recorded surgical procedure was done. But later on, even the FDA, they have not done much of a study or deliberations on how it has to be, regulation has to be. Too tight a stifling over-regulation or under-regulation is going to create a problem. And lack of experienced regulatory bodies, even in India also we are all doing. And across the mentoring the patient, persons, informed consent, how it has to be, there is no documented thing, like how the informed consent has to be. And technology impact on the doctor-patient relationship. So whether it's going to be unlikely to become a mainstream technology until the costs reduce. And finally, what we ask is, there are some areas where the robo is going to do radical prostatectomy, partial nephrectomy. Others, whether to an 18-wheeler machine is required or a vehicle is required to get a quart of milk from the market. So finally, I am not a AI pessimist, but you can see in the broad daylight what it has happened on 1/6/2020, exactly almost 2 years back at 6:44 broad daylight. You can see a vehicle there, the AI has hit it, everyone can see. See another car driven by the human, it's coming there, he sees that accident, he stops and slowly takes a deviation from there and takes and goes out of there. This is what the problem is, an autonomous robo, what it will do. This was recorded, this has happened, and this is going to happen in the future also. Thank you very much. And finally, I am not an AI pessimist. Thank you.
Thank you. Very nice lecture. So what do you think is going to happen in future? You think that all these changes will come with artificial intelligence? Maybe not 5 years, 10 years, but maybe 15 years. Because see, now the driverless car actually is coming into reality, although now we have seen all these problems and other things, but they are going to overcome those problems. Most of the pilots, it is autopilot mode, and the pilot's job is just to see that everything is going on well or not, and if there is any problem, take over the control. So do you think that maybe 10-15 years down the line all that will come so accurately?
I fully aware of the developments happening in the field of AI. It is like, if you don't use the AI, you will be replaced by surgeons who will use the AI. It is complement our surgical skill, but it's not going to replace even in the future. As long as the cognitive function is God-given, those kind of efficiency is not given to the transferred into the
It will always complement.
It cannot replace. Okay. Thank you very much.
Thank you very much. I think that was very well studied presentation, well prepared presentation. Thank you very much. I think with that we come to the end of this whole session.